Healthcare runs on thousands of decisions made every day: clinical, operational, and financial. Revenue cycle management is where those decisions meet reality and where precision, context, and accountability matter most. Smarter Technologies brings clinical intelligence, AI, and human oversight together in one coordinated platform, helping health systems document, code, and capture their work accurately, compliantly, and at scale. Because when teams can trust their technology, they can move healthcare forward. Learn more at smartertech.com.
Welcome to the Heart of Healthcare podcast. I'm Halle Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the show. I'm Halle Tecco, and I'm here with my co-host, Steve Krause, to bring you the top headlines for the last month in digital health. Steve, hi.
It's so much going on, Halle. But we got a bunch of good stories this month, so excited to get into it.
Yeah, so I wasn't at JP Morgan, but maybe for our listeners, you can give us like the very quick recap of what happened.
Well, I was there for a day.
Oh, wow.
So,
okay.
Yeah, in and out.
That's enough. That's enough.
It was good. No, I always like JP Morgan. It's like a good way to start the year. I would say a lot more positive this year, I think, because of the AI hype and hope as it relates to our industry. I think generally, despite all the turmoil in in the economy and our democracy, like public stocks have been generally doing really well, right? So I think the public track was generally had pretty good news. Lots of involvement from the government, which I found interesting. Like all of the
they were all there.
CMS, HHS folks were all there, talking not just about AI, but frankly, value-based care and what they hope to do there, and automating the payment rails, which I think is promising. And
do you want to share who from government you're speaking to on the show soon?
Oh, yeah. We're going to have Chris Klomp, who's the head of Medicare and a deputy secretary for HHS, also was a former entrepreneur that I backed and just an overall great human being, is going to be on the show in a little bit, which will be awesome to talk to him about how policy is going to be shaped looking forward. All
right. Well, let's dive into it. I'll go first. So a big question that we all have is when, not if, AI will be able to prescribe medication. Well, the answer is it's happening. AI is now prescribing medication. The very innovative state of Utah just launched a pilot program that allows AI to autonomously renew prescriptions for chronic conditions. It covers about 190 common low-risk drugs like statins for cholesterol or birth control, stuff that usually just requires a routine like checklist review. They've done clinical testing on this. So the AI tool that they've been using, it matched the human doctor decisions over 99% of the time. It's designed to be on the more conservative side. So if a patient reports a new symptom or a weird side effect, the system automatically kicks the case to a human physician. It also only costs $4 per renewal, which you can imagine, like there's room for it to even go down from there. But $4 compared to a clinician visit is quite a cost savings. And so the goal is to prove that by offloading these routine tasks to a validated AI tool, we can stop the quote unquote medical lapses that happen when people just can't get to an appointment, can't afford to get to an appointment, and also frees doctors up for patients who really need them.
There's just so much AI news this month, and as our listeners will hear, and this is like
the AI show, the heart of healthcare AI.
Yeah, I know. I think this is really interesting because, frankly, a lot of the AI that we've seen to date, and frankly that we've invested in at Bessemer, has been more focused on the back office of healthcare, as we call it, like RCM and patient scheduling and triage and call center and all this stuff. And yet we know that I think there's so much power for these technologies for clinical care, improving it, right? And increasing access and speed. I think this is a tip of the spear in terms of prescriptions are obviously a relatively simple task, but huge news for our industry, like huge news. It can't be understated how big this is. I think there's so many interesting pieces, it's at the state level. So how do we think about state and federal regulation? We're going to talk about that in a little bit, but we've talked about in prior shows, it's unclear who's going to regulate this stuff, not just in healthcare, but broader AI. But that's really interesting to see how that plays out, because clearly Utah is getting ahead of the federal government on this, honestly. And so
would you have guessed Utah if I was like, hey, Steve, there's a state in the US that's testing out AI for renewals. What state do you think it is? Where would Utah have been on that list of guesses?
I mean, Utah is a pretty entrepreneurial area, right? I mean, that is true. And I think this is pretty innovative. So good for the state of Utah.
Super awesome.
So that's one thing, state versus regulatory. And then I think the whole idea of all of a sudden we take the physician, patient, AI triad model and make it a dyad model, right? Which this is, right? This is just AI and patient, right? Yeah. Now who holds the liability when it comes to malpractice? And I think it sounds like Doctronic got a unique malpractice policy. I'd love to learn more about that. By the way, it made me think, again, not just for healthcare, but other industries, there's going to have to be all these commercial insurance underwriting that happens. And I think right now there must be an amazing arbitrage opportunity for these insurers, because presumably we're all going to think these things are more risky than they are, these LLMs. And in truth, we know that they're almost superhuman in their capabilities. I mean, I don't want to overstate where they are today.
Right.
So I imagine
these
policies,
cars. Yeah.
Right. I imagine these policies are being written really conservatively. And so the premiums are relatively high versus the risks they're taking on. But we'll be interesting to see that over time. That was another thing I thought when I saw this.
Yeah, I hadn't even thought about that. But yeah, I mean, the question that we always hear when we talk about AI prescribing, which I think we all agree is going to be the future for at least a certain set of medications, is like, who do you sue when things go wrong?
Right.
And so Doctronic, which is the company that really is powering this, they created this bespoke malpractice insurance that you're talking about that treats the AI system like a licensed doctor for liability purposes, which makes sense, right? Like then that company is responsible for ensuring that the LLM behind all of this is accurate and not going to hallucinate or go out of bounds, because that's on them. So.
Yeah. The final thing I'll say on this one, because I think it's such an interesting topic, is to date, the AI, as you said, has been almost equivalent in terms of safety to a human clinician. I know there's going to be headline stories when the AI messes up. And I just think there was a great point made on Health Tech Nerds, one of our favorite sites, is like, let's make sure that when we're comparing the baseline, we also have to be mindful of like the humans aren't perfect either, far from it. And so that should be the baseline when we compare at the end of the day how this works.
Or just not accessing care.
Yeah, they're going to be negative stories. Yeah. They're going to be negative stories for sure.
Yes, there will be.
Yeah. Well, okay, so speaking of AI, we talked about how Utah as a state's taking a forward-looking regulatory policy, and frankly, it's been unclear what the federal government was going to do. Now, we knew the administration was generally AI and innovation friendly. They've made that clear. They wanted to take a more hands-off approach. But this past month, they issued two interesting guidances. One was around clinical decision support when it comes to using AI to help make clinical decisions.
So like an open evidence.
Like an open evidence, or even like sepsis, frankly. Before, the way this worked is if your AI recommended just one, if it came up with one specific treatment diagnosis, like this is the diagnosis, it was determined to be a medical device, and you'd have to get full FDA review. You'd have to go through a whole 510K or PMA process, which, as we know, takes a lot of time. The new rule is that, frankly, if a doctor is involved and either your AI offers multiple options, or there's deemed to be only one clinically appropriate decision that the AI generates, and then you have a clinician involved to review that no longer needs FDA approval. And so I think it's going to allow for a lot more of these sort of AI clinical decision support tools beyond just what open evidence does, but like in every single different ology, in every single different specialty area, to get to market faster. Really big change that it was promulgated. And I think it's going to have a lot of positive effects for the innovation community in terms of people, the ability to develop these technologies and access the market quicker.
I heard Reid Hoffman say on his podcast that if a doctor isn't using AI, and I assume he's meaning these clinical decision support tools, that's almost considered malpractice, he said. It's an extreme point of view, and we're going to talk about a case where a clinician used AI and it didn't go well.
Way. Yeah.
Went the wrong way. I think there's a lot to unpack here. I mean, it's obviously going to be helpful to speed up innovation, but it's also going to speed up like the learning curve for clinicians on using these tools and hopefully figuring out a way where they're not becoming dependent and like losing, like we don't see like a de-skilling that I think a lot of people are worried about.
Taken to its full extent, these AIs supposedly are going to become almost like superhuman. If that is true, I still think there's going to be a place for a clinician because by definition, they're not going to be able to diagnose every single case, right, definitively. And so there's going to be gray areas. And that's where I think the clinician will need to be second line. So they're almost going to have to be smarter and more specialized than the AI themselves. Do you see what I'm saying? I mean, I get your point that maybe in the interim period here, it could lead to de-skilling because you almost defer to your point, the driverless car to drive here. But I think ultimately at its end state, if humans are going to keep up with these AIs and there's going to be a role for clinicians, which I absolutely think there's going to be, in addition to obviously putting their hands on patients and doing surgeries, I think there's going to have to be definitive diagnoses where it's unclear what the AI decides. So to me, then the human has to almost be smarter than the AI.
So do you agree with Reed that we should, you probably don't agree that we're at that point now.
No.
Would you agree that we should get to a point where like doctors need to be using these tools because they are so helpful that if you're not using AI in your practice, that you're not doing the best work you can do?
Everyone needs to understand where AI fits in the world currently and like how do you use it? And I think that applies to our clinicians too. Like I think for even surgeons, we talked about how there's a need for surgeons. Like, you know, in truth, if you take it to its end state, robotic automation is not going to eliminate, again, all surgeries, but a bunch of surgeries. And so you need to understand, like, how do you use this stuff? So yes, I think the answer is yes. And to the medical malpractice point, this is why that Doctronic case is so interesting. Like, presumably this stuff is going to drive down malpractice if it's more accurate and better.
If it is actually better, yeah.
Which is a bane to every single clinician's existence, like the medical malpractice expense that they have to absorb, right? So yeah, I think I'm probably going to take the bet on the side of these technologies getting better. Zeke Emanuel on the last podcast, one of his friends said to him, the AI used today is the worst AI you're ever going to use.
It's interesting. I just finished Bob Watcher's book, A Giant Leap, which is about AI in healthcare. It's coming out this week. Anyhow, one of the things he talked about, which you and I have talked about, is about how we thought 10 years ago that AI was going to take over radiology. Like everybody kind of agreed and like thought like, yeah, of course, this makes a lot of sense. It's just like pointing to things on images. But he mentions in his book that one of the reasons it really has not is that like missed cancer is actually the most common cause of successful lawsuits against radiologists.
And by the way, in this sort of promulgation and the guidance that we talked about, anything analyzing images or signals still needs to be regulated. So, you know, that speaks to that point. Anyways, I think you have another AI story.
I have another AI story, and it kind of like brings these two things together, like when we have clinicians that are using AI. So a 35-year-old man, well, he was 35 at the time, but he is suing the whole body MRI provider Prenuvo after his $2,500 elective scan failed to spot the warning signs of a stroke. So according to the lawsuit, Prenuvo incorrectly labeled the patient's brain scans as normal, despite a clear narrowing in a major artery. And 8 months later, the patient suffered a catastrophic stroke that left him partially paralyzed. Understandably, he's very upset. Prenuvo attempted to limit the financial risk by arguing the case should follow California law, which caps malpractice damages. I wasn't aware of that. But a New York judge rejected it, said no. And so it's interesting because Prenuvo, we've had the CEO on this podcast, they have long promoted its use of AI to, and this is what their website says, quote unquote, to support the radiologist by enhancing image quality, speeding up scan times, performing measurements, and flagging potential issues. So they used, this clinician, this radiologist had AI, had all the tools, presumably the most innovative MRI full body scanning tools out there. And this wasn't a false positive, which we spent a lot of our time when people analyze companies like Prenuvo, we talk about the cost of false positives. This is a case of the cost of a false negative.
Yeah. I mean, this is the point of these technologies, and I want to talk about this because I've actually had a Prenuvo scan. Have you?
No, I'm claustrophobic.
Oh, really? Oh, it's so the actual user experience is amazing. I was able to watch like a
Really?
Netflix episode. Yeah. I mean, it's a little tight. My fear is that people are going to use these, new consumer-oriented functional medicine, things like Function Health and Prenuvo, which are great. I mean, I think they're pushing consumerization in our industry, but I do think you need to also take the results, which is what I did, and take them to the as-is system to get a second opinion on like, okay, Prenuvo tells me X or Function Health tells me Y. Like, go get a second opinion from your primary care doc.
It's interesting because there was a cardiologist on social media, Dr. Sayeb Panwar, who said that the entire report reads like AI-generated slop with barely any details that I would see in an actual radiologist report. This kind of ties into what we were saying before. Was this radiologist, just like signing off? Does he have such a big workload? Is he getting paid per report? So he's just like signing off on them and trusting the AI to see stuff. If you look at the lawsuit, you can actually see the images. I'm not a radiologist, but they like circle the part where like this should have been picked up. So
and it was obvious. They're claiming it was very obvious.
They're claiming it was obvious. Yeah.
Yeah.
So
I think
it goes back to like who is liable. That obviously in this case the clinician is liable, but like is this a lesson of like
Well, I assume the clinician Prenuvo is liable here, obviously, because the clinician works
Prenuvo.
for Prenuvo.
Yeah.
I mean, I do listen. I think it's on the one hand, I think most people are trying to take these tests for peace of mind or to see if they found something. I'm not defending Prenuvo, I think, but I think we also have to understand what the baseline is, which is stuff is missed by doctors every day. And
totally.
Not doing it, this human being still would have the same issue. All right. Well, speaking of companies that are in legal lawsuits,
where's
Epic,
Michael when we need him?
Epic, the 800-pound gorilla of the healthcare IT industry. Very interesting. I mean, has been involved in a lot of legal morass recently with Particle Health, Epic suing Health Gorilla and others that they think are violating TEFCA and trying to access data, and using it for commercial purposes rather than use it for clinical purposes. But now, in addition to all that, which has previously happened, now the state of Texas actually is suing Epic and accusing it of monopolistic behavior. The Texas Attorney General, who I'm not a huge fan of, Ken Paxton, basically filed a lawsuit against Epic and claimed that they run an anti-competitive playbook to maintain its health records monopoly. They claim that Epic restricts people's access to data. They claim that Epic has pursued predatory pricing when releasing new products to try and gain share in the market, and then over time will increase its pricing. They also claim that Epic promises a really broad roadmap, future product development to create FUD in the market to stymie innovation. So frankly, Attorney General Paxton claimed that Epic was woke software, which I didn't quite get that.
He used the word woke software?
He used woke because he said that it was restricting parental access to patients, to minors' records, to their kids' records.
Aren't they just following law?
Yeah, part of. So that was a little bit crazy to me. But I think it is actually pretty notable that a very large state,
for sure,
which tends to skew more Republican and also more pro-business, is the first on record to sue the largest healthcare IT incumbent. And one where, frankly, if you talk to entrepreneurs in our industry, they kind of look and say Epic has created a lot of challenges for us. So what do you think, Halle? I mean, this is like, we've talked about the PBMs and what's going to happen with them, but maybe this is the year that Epic faces legal challenges.
We've talked about the Health Gorilla and Particle Health lawsuits as well. I mean, clearly they are being anti-competitive. I mean, they have multiple allegations of this. And as you said, any founder that you ask has probably had a similar experience.
Oh, gosh.
Yeah. So it feels like maybe this is a moment for it to be bipartisan, where we recognize that innovation in the EHR space and provider software space would be better if Epic wasn't so anti-competitive.
Back to Bill Gurley of Benchmark's famous YouTube speech is they have a lot of regulatory capture and power.
Yeah.
So, we talk about Epic, we talk about the PBMs, and I am hopeful that some of these things will force them to be more innovative, more open, more collaborative. But
I mean, they haven't made friends. Let's just say that. Epic has not made friends with the innovation community.
All right. Well, we did AI, we did Epic. Now it's time for
GLP-1s. So a new study out of Aon, the insurance company, they tracked 50 million people over 2.5 years to see the impact of GLP-1 medications on healthcare costs for employers. And the research found that patients who stayed consistently with their GLP-1 treatment actually saw 9% lower medical costs compared to those not on the drugs. The long-term savings came from a major drop in expensive medical emergencies, including fewer hospitalizations for strokes and heart attack, as well as, shockingly, and I almost don't believe this, but a 50% lower incidence in ovarian cancer in women. Yeah, obviously this is observational. They're looking at real-world data, but that is something I hadn't heard before, so fascinating. So the problem is that these drugs are currently driving a 10% spike in employer healthcare costs for this year. But the data suggests that the high adherence is really the key for flipping the script on these. I mean, to see, this sort of ROI in a 2.5-year time frame is great. Obviously, though, health insurance is on a 12-month time frame. So would be interesting if they had kind of calculated that separately. Like, where does the ROI, what's like the payback period? So yeah, what's your thought on this? I mean, what percentage of employers offer it now? Not many.
Yeah. I mean, well, we talk about AI a lot, but like 9% lower medical cost, right? I mean, if you, and not that this drug is for everybody in our population, but it's for a lot of people because a lot of people suffer from obesity or maybe some of these other disease areas, because now it's shown to have impact, as you said, on so many other areas. That's just like so massive, given that healthcare is the largest cost driver for our country. There's a reason why Medicare is going to cover it, right? And employers aren't. But I'm optimistic about that because right now it's a relatively high cost injectable, right? But there's the scale of and speed of innovation here is amazing, right? Because both Novo,
like AI.
it's I mean, it's a parallel, but in the therapeutic world, which is so cool, like the innovation that's happening. But like Lilly and Novo are both coming out with oral formulations. In fact, Novo's already done it.
It's already out.
That one's got some issues. Yeah, that one's got some issues in terms of like when you have to take it and on what and nutritional guidelines around it because it can have some side effects on an empty stomach and the like, and it doesn't work as well. But the Lilly, from what I hear from my friends in the industry who are experts in this area, the Lilly drug is like super powerful and doesn't have the side effects. Basically, has the same weight loss almost as the injectable. Lower cost because by definition, oral drugs are much cheaper to make. Frankly, I think is going to be more accessible to so many people because you've talked about fear of needles and frankly, just taking a drug, I think daily can become more part of your habit than necessarily self-injecting. So I think the ROI that we're going to see as society and the cost curve is going to go way down. So,
absolutely. And I mean,
so employers are going to cover it. I mean, that's where they're going to go.
I mean, the big piece, my big takeaway from this is like, adherence matters, right? Like this is you only see a lower medical cost if people stay compliant on the treatment, which is something that you have to take for maybe for life, but at least for a while, for 2.5 years. The biggest issue has been cost. Adherence has been like hampered because the cost is so high. It's just once you lose the weight, you're like, I can't afford to be on this anymore. Yeah. But now that the price is going down, I really feel like digital health can help with some of the other adherence issues. And that is like supporting and managing the symptoms and supporting and managing like nutritional education and not like combating muscle atrophy and all the other pieces of lifestyle changes that are required to stay compliant and make sure that the GLP-1 is working. So for companies out there, I mean, this has been in a lot of ways like a land grab over the last couple of years with virtual prescribing. But in my mind, like a virtual prescriber is better positioned than an in-person clinic at this point because clinicians do not have the time to follow up and do the educational component of prescribing this. But this sort of study is a great turning point for us, and hopefully employers can like look at this data, look at the ROI, look at that combined with the costs going down and think about better ways to deliver GLP-1 care with the digital health wraparounds so that employees can benefit from this.
Yeah. All right. Final story for this month. A really interesting article I saw that healthcare, which has been driving our economy in terms of job growth, healthcare accounts for like roughly 14% of the overall workforce. Healthcare has been losing its steam in terms of the amount of folks that are hired recently. Basically, in 2024, about 56,000 new people were employed in the healthcare industry per month. And last year, that number decreased to 34,000 healthcare jobs added per month, according to the Bureau of Labor Statistics. So there's concerns about the economy, and our industry is one of the largest drivers of net new job growth in our economy. There's plenty of reasons for it. Lots of things we talked about on the Heart of Healthcare, Halle, right? The one big beautiful bill. Well, maybe it turns out it won't be so beautiful when it comes to, actually the impact on the economy, not just on people and Medicaid. It's obviously causing providers to feel a lot of pain because they get a lot of their reimbursement from Medicaid, and that's one issue. Actually, a thing I hadn't even thought about, caps on federal student loan borrowing could push students away from clinical careers and pursuing advanced degrees, which leads to more healthcare workers. And then we have talked about the issue of right now, which is super present in our life and our national discourse, the deportation, the ICE raids, which are horrific, but the impact that has on fewer foreign-born health workers opting to come to the U.S. And a lot of the home health aides and other industries are powered by that part of the population. And then, of course, AI, which we've talked a lot about in this podcast and others. And, the fact that, frankly, health systems are looking at it not just for improving clinical care, but also stripping out costs. So warning signs to the economy if the major driver is
worsening,
decreasing the amount of jobs.
Yeah. And to healthcare, just like worsening, like shortage.
Access.
So, like all of this you're saying, yet premiums are going up. So like we're spending more money on healthcare this year, even though we're losing the bodies, like the labor, which is one of the biggest inputs to healthcare. So who's winning? Like where is that going, right? Like we have more money being poured into healthcare, but fewer people providing it.
There's a really interesting study that McKinsey does with the profit pools. The short answer is I think specialists and specialty pharmacy are the big winners. Yeah. A lot of people say the drug companies themselves or insurance companies, but the profit pools there are actually pretty small. Whereas there's some niche areas where the profit pools are pretty large.
Okay. For March.
Well,
awesome.
Your book.
Yeah, well, it's under me. Let me pull it out.
February's the book launch.
This
everyone,
month,
massively better healthcare.
We've already sold out, so they had to this week they're doing another run.
I had to pull some strings to get a copy.
I said my publisher was like, "This is a good problem to have," and I was like, "That you didn't order enough because you didn't think it was going to be successful."
Right. Right. You're like that. You're like that Novo exec that's holding the supply chain guy accountable when they ran out of GLP-1s.
Yeah,
they ran out of massively better healthcare.
Well, listeners, please go to massively-betterhealthcare.com to see my book tour. I will be all over the U.S. Steve, I'm coming to Boston. So
can't wait.
Yeah, I'll be Boston, New York. I'll be at HIMSS in Vegas. I'll be at Together at Collective Health in Arizona. I'll be at Health in Amsterdam. I'll be at Wired in London. I'm in San Francisco now in early Feb for a few events. So would love to see listeners in person and hear your stories and learn about what you're working on. So thanks.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Halle Tecco and hosted by Michael Esquivel, Steve Krause, and Halle Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.